Good morning, good afternoon, good evening, wherever you are. Welcome to Virtual Grand Rounds in Thoracic Surgery. Premier education brought to you at no cost, thanks to our sponsors, Medtronic, AstraZeneca, and Medela, the Science of Care. This week, it's a great delight for me to present Professor Mong-Wei Lin from Taiwan to talk to us about artificial intelligence in thoracic surgery. Professor Lin, over to you.
Okay, thank you. Good morning, everyone. My name is Mong-Wei Lin, and I'm a thoracic surgeon at National Taiwan University Hospital in Taipei. So it's a really honor to be invited to the virtual grand round at Imperial College London to share some thoughts on AI in thoracic surgery. So no conflict of interest. So this is the outline of my talk today. Over the next 15 minutes, I would like to walk you through 4 parts. I will start with a brief introduction to set the scene of AI in thoracic surgery. Then I will focus on the main part of the talk, the application of CT-based artificial intelligence for surgical planning in early-stage non-small cell lung cancers. Here I will mainly share the work from our own team and how we try to use these models in real clinical decision making. After that, I will spend a few minutes on metaverse in thoracic surgery, showing some early examples of how immersive AI-enabled environmental might support both clinical practice and medical education. And finally, I will wrap up with a short conclusion. So in recent years, AI has advanced rapidly in medicine. We usually talk about two main methods, traditional machine learning with handcrafted features and deep learning, where the model learns features directly from the image itself. And this slide shows the typical workflow of traditional machine learning in radiomics. It can be broken down into 5 main steps: input image, preprocessing, feature extraction, feature selection, and model building. In the preprocessing step, earlier studies rely heavily on manual or semi-automatic annotation of the lesion, but today more and more automatic segmentation tools are available, and their accuracy has become reasonably good, which greatly reduces the manual workload. And in the feature extraction step, we focus a lot on the texture feature. There are many commonly used feature panels, such as GLCM and others. You can think them a little bit like different NGS gene panel. So each panel can generate dozens or to thousands or to hundreds a texture that you can try to capture the heterogeneity of the tumor. And in addition, we also extract the histogram features and also some morphologic features. And all of these are treated as radiomic descriptors at the feature extraction step. And in the feature selection and model building stage, we start from hundreds of extracted features and narrow them down to a small subset, maybe 4 or 5 features that carries most of the predictive information. And these selected features are then fed into the standard classifier, such as a random forest or SVM, to build the final prediction model. So now move on to the deep learning. In a convolutional neural network, we no longer handcraft features. The network takes the raw image and through conventional layers, automatically learn local patterns such as age and texture. So by stacking many of these layers, the model builds a hierarchy of features. Low-level edge combine into a part, and the part combine into a object. So from simple line, it can recognize complex patterns like cat, or in our case, a long nodule. So these high-level features are then passed into 4 connected layers, which project them into a new feature space where the classes are better separated. And a simple classifier at the end can then output the final prediction. For example, the malignant versus benign. AI can assist almost every step of the clinical image workflow. So in today's talk, I will focus on the characterization stage, especially on segmentation of lung lesion and also on the diagnosis, including identifying important pathologic features from lung cancer CT images. So far, this brief introduction, I would like to move on the application of CT-based artificial intelligence for surgical planning in early-stage non-small cell lung cancer. So everybody knows that a lung cancer surgery can be broadly divided into lobectomy and sublobar resection. And lobectomy usually provides a wide resection margin, whereas sublobar resection can preserve more lung parenchyma and lung volume. And regarding to the choice between these two procedures, after landmark RCT by Ginsberg in 1995, lobectomy became the gold standard for early stage lung cancer in the next 2 decades. However, in the era of low CT screening, should lobectomy still be the standard operation for all early stage lung cancer patients? I think maybe not. Yeah, so we can see that from 2000 to 2010 in the United States, there was a clear trend. The proportion of patients undergoing sublobar resection increased year by year. And now we finally have the second and third RCTs from both Eastern and Western populations show that sublobar resection is a reasonable option for peripheral lung cancer smaller than 2 centimeters. However, we also realize that some tumor size alone may be not enough to decide the surgical method. So I think other factors clearly influence how we choose the surgical procedure. For example, for these 3 patients, I think different surgeons might reasonably choose different kind of surgery, lobectomy, segmentomy, or wedge resection. Yeah, so I think ideally, our surgical decision should be decided by the underlying pathologic feature, not just tumor size. For patients with high risk pathologic feature, we would prefer lobectomy to secure a wider resection margin. In contrast, if there are no high risk feature, a sublobar resection may be adequate, and it has the advantage to preserve more lung function. So what is the high-risk pathologic feature in early-stage non-small cell lung cancer? I think they should include the LS3 feature, high-grade histology subtype, stars, and also visceral invasion. And the key point is that when these features are present, patients who receive only sublobar resection have a much higher recurrence rate high risk of recurrence, whereas the difference is not seen in the lobectomy group. So these pathology features are crucial when we decided between lobectomy and the sublobar resection. But the problem is that we only know this pathology feature after surgery from the final pathology report. So how can we identify tumor with high-risk feature before surgery? The most common is to do needle biopsy. But the tissue we get is often very small sample, and the procedure can distort the histologic pattern. So in contrast to needle biopsy, the image-based assessment that covers the entire tumor can offer a much more comprehensive view of its characteristics. So in early of this year, in AATS annual meeting in May, there is a debate titled Sublobar Section Pathology of Radiology Determining Best Operation, and there's a vote. So interesting, about 50% of the audience voted radiology. So I think probably because the radiologic information is available before surgery, so many surgeons still rely on CT features to decide the extent of the resection. But this also highlights that we really need a more objective, quantitative tools to support these image-based decisions. Yeah, so about 10 years ago, our team started to use CT-based radiomic analysis to predict these high-risk pathology features. In 2018, we published our first study using so-called near pure tumor, a lesion in which almost the entire tumor was composed of a single subtype. So we can know about the radiomic feature of each subtype. And the model achieved a very good predictive performance. So we also present the result at World Lung in 2018. And because the presence of a high-grade component has a major impact on prognosis, Even a 20% high-grade area is enough to define a tumor as high risk. So next, we focus on the detection of high-grade components and publish a study specifically on this topic in European radiology. And we also develop a deep learning model to predict the high-grade subtype using CT image to automatically learn the pattern associated with these aggressive components. And STARS is a very important pathology feature and was proposed in 2015 as a new pathology feature associated with a high risk of recurrence in lung cancer. Our group was among the earliest team worldwide to report a strong association between STARS and postoperative recurrence. And we also use a machine learning approach to build a STARS prediction model. In this work, we first segment the per-tumor region on CT, and then apply the high-grade texture feature we had identified in our previous study to construct a model that could predict the presence of stars. And this model showed very good predictive performance. And when we validated it in an external cohort, it was able to stratify patients' disease-free survival and also overall survival quite effectively. And we also developed a deep learning model to predict the stars. The performance of this prediction model was actually better than the prediction made by a thoracic surgeon. You can see the point is a thoracic surgeon, the prediction. The performance is quite high than the surgeon. And we also built a CT-based radiomic model to detect invasive components in pure ground glass opacity, aiming to distinguish a truly indolent lesion from those that already contain an invasive focus. And we also developed an automatic 3D segmentation pipeline of the pulmonary artery and aorta from CT, allow us to quickly create the patient-specific PAO ratio for further analysis and planning. And based on the model, we further show that the automatic measurement of the PL ratio can help predict the postoperative complication after lobectomy. And we also recently published a deep learning model for CT-based prediction of visceral invasion of lung adenocarcinoma, and the performance is good in both internal and external cohort. So after we did a series of studies, so we built on the series of study and predictive model. So about 2 years ago, we launched an industry academia collaborative project with a goal to translating this research finding into a real clinical practice. So we integrated our model into a nodule detection platform called LibraLung. And the idea is that the clinician can select a nodule of interest and run the AI prediction and immediately get a report. For example, that the tumor has a high probability of harboring high risk of pathology features. And this can give a more objective reference when deciding to decide whether a wide resection, such as lobectomy, is necessary for this patient. So this is the lung nodule detection platform, is the LibraLung. And this platform has been approved by FDA and Taiwan FDA. And this is the actual interface of the platform. After we clicked on the nodule of interest, the system generated a pathology-like text report, just like you see it in a pathology report daily. And the report, including the consolidation to tumor ratio, and the prediction subtype, stars, and the visceral invasion. So show the probability and also the probability is high, moderate, or low. So surgeon can then use this information to help decide the appropriate extent of the resection. So in the third part of my talk, I would like to very briefly share how our team is exploring another emerging technology, the metaverse, and its potential application in thoracic surgery. And this slide shows our system, the Opverse. It is an extended reality system. So we start from a routine thing called CT to create a 3D model and bring it into the VR environment so that surgeon can actually walk around the patient's chest. So this kind of metaverse platform can be used for the MDT planning and explaining disease to patient and teaching trainees and even remote collaborations. So we also test the system in a clinical trial for uniportal valves. So resident can use the XR simulation to plan and mark the optimal port site before surgery, instead of relying only on their very limited experience. So I think it's currently being evaluated in a randomized control trial in our institute, which is now actively enrolled patients. So here you can see that the real uniportal thoracoscopy view on the left side is almost perfectly match the preoperative upward simulation on the right side. So by helping us choosing the optimal port site, I think this system may shorten the operative time, especially for those with not so many surgical experience recent. And this shows the conventional CT-guided preoperative localization method in our institute. And sometimes we will localize the nodule in hybrid OR. And it's great to localize in hybrid OR, and patient is very comfortable. But the setup is really expensive. So I think not every hospital can have it. So in the second trial, we use the XR system to assist the CT-guided localization of pulmonary nodule, mainly to reduce the repeat scan, to reduce the radiation exposure, and to speed up the procedure. So we plan to enroll 20 patients, and so far the localization error is just around 6 to 7 millimeter. So I think this range of error is quite acceptable for suborbital section. And you can see that in the illustration, we use XR assisted CT-guided technique and to precisely localize the lung nodules. So the metaverse is now also integrated into our surgical teaching program at National Taiwan University. So it's our real picture with our medical students. So we can create a case-specific metaverse teaching module for individual patients with our in-house software. Students can zoom in and zoom out, pre-rotated the 3D structures, and show or hide different organs and compare them side by side with the actual CT image. So they can learn the surgical anatomy. So it's the conclusion. So in the conclusion, I think radiographic evaluation prior to surgery serve as an essential guide for determining the appropriate extent of lung resection. And beyond tumor size, location, and CT ratio, I think additional radiographic feature is very important and should be considered to refine the decision-making for suborbital resection. And the future predictive model should aim to be both accurate and also clinical feasible. And finally, the AI-enabled metaverse application may further enhance thoracic surgery in both clinical practice and medical education. So finally, I would like to thank of my colleagues and some, not only in my institute, but also some friends and some institutes in United States. Thanks to them for supporting our study and our clinical practice. So thank you for your attention.
Thank you very much for an amazing presentation. Um, I'm going to start with one or two questions, if that's okay. When you say high-risk features in your talk about external resection, I presume risk refers to recurrence-free survival or recurrence of disease.
You mean the high risk of patient? Yeah, I think in many retrospective study already show that if we have if the patient have such kind of high risk pathology feature, if you do the suborbital section, both the disease-free survival and the overall survival is poor compared to the lobectomy group. Yeah, but if you do the lobectomy, I think the stars, yes or no, will not influence the surgical outcome. So it's more crucial for patients who receive subarachnoid resection. So I think in the memorial zone cathetering, I heard that they even if they do the subarachnoid resection and show the stars positive, they will do the completion lobectomy after surgery. Yeah, but I think there is still not so many evidence. But it indicated that for subarachnoid section, only the high risk pathology feature is very crucial. Yeah,
Do you think we need more clinical trials to validate that proposition? Joseph
yeah, yeah.
Lucardi and myself are actually going to ask the same question. In the World Conference this year, the JCOG 0802 presenters went on stage. Yatabe presented that even if you did lobectomy or if you did segmentectomy, if you had stars, the recurrence was the same in both groups.
Oh, yeah, yeah. I see some results show the results. So I think stats is also a very interesting issue because even I think even the definition of stars it has some controversial, and some experts think the stars should also have the degree of stars. For example, some is like the VPI have P L one and P L two. Yeah, so I think the one of the reason why many study have different conclusion maybe because the definition of stars may be quite different from different experts or different countries, and also some artifact. For example, some experts say that the special surgeon, yeah, by squeezing the specimen, yeah. So yes, I see the report, and right now it's still controversial, but I think stars is also for me, I believe that subarachnoid section, if you have stars, yes, maybe the patient is under high risk of recurrence. Yeah.
A question from Chai-Yin Lim, who's asking, your training models would be done on the normal varieties of lung cancer. How would it, presumably it would not be able to spot rare tumors with high risk features, for example, large cell neuroendocrine tumors, which are rare and also aggressive.
Yes. Yes, I think it's a very good question. Because in different countries, the proportion of different subtype of non-small cell lung cancer is quite different. In Taiwan, because our program and our study mainly did in Taiwan in multi-center trial in Taiwan. So our population, I think the majority of the image is from the lung adenocarcinoma. In Taiwan, about 80% is lung adenocarcinoma. So I think if the program and the platform can be applied to other population, to other country, I think need to in, need to incorporate it at other cohort to make fine tune. And I think also if other country or other institute want to test our platform, I think maybe it's better to do some retrospective test at first. You can test the specimen, the image, and you already know the answer to test if it's applicable, and maybe have to do some fine tune. Yeah, for the model. Yeah, it's a very good question.
That brings us nicely to Pierre Mordon's question, who's asking, have you made any attempts to externally validate your AI models in other populations?
You mean did we have external validation of our model? Yeah, actually, we every study we publish, we did external validation from two different hospital. It's quite away from our hospital, so we have some external validation. Yes. Yeah.
Dr. Mahmood is asking, how long do you think it would be for your technology or technologies like this to be implemented routinely in clinical practice elsewhere in the world?
Okay. Okay. I think yes. Right now, not only our team, I believe many different teams do the similar things. Yeah, Be- because the AI technology improved quite good. But I think right now it's still in the stage that the model can assist our decision, but cannot directly make the decision. So if one model you can apply to the different country, you have to validate by many different country. And also, in our experience, we will not use in every kind of patient. We only use it in very somehow it's a controversial case. For example, 2 centimeter and a solid and it's a borderline to do wedge and do thrombectomy. But back to the question, I think only the most important thing is that we have to validate in different population from other country. And also we cannot only I believe that the prediction model, you can only show the good performance only. I think it's better to initiate a randomized control trial to prove that if you use this model or not use this model, and it really improve the outcome of the patient. Because I think every intervention, not only drug, not only surgical technique, but also such kind of prediction model. The final goal is to improve the patient's outcome. Yeah, so I think it's good if the model really can change the physician's decision in a controversial case, and the change will lead to the improved outcome. I think at that stage, maybe it can application to all around the world. Yeah.
We had a lot of discussions here in the UK about sublobar versus a lobectomy. And one of the questions was posed by Adrian Marchbank, which I'm going to ask here because he's been a bit quiet today, is that do you think these AI models in radiomics will be able to predict STAS or other prognostic features reliably that we can use independently so that we can, or is it a black box, or can you predict STAS or specific features? How does it actually work?
Um, Sorry, can you repeat it? Sorry.
Can
You
these
mean?
radiomic or AI radiomic predictors look at STAS
Yes,
reliably, or is it black
yes.
box? It is just high risk versus low risk.
Oh, we can predict the one pathologic feature reliably because our prediction model we focus on three different kind of pathology feature, and I think we both use machine learning, so we know what kind of pathology feature, the radiomic feature we use, and also we use deep learning model for the specific pathologic feature. For example, to predict the stars and to predict the subtype, high-grade subtype, and also the visceral invasion. And then we merge every single model to merge it together for the prediction of the whole pathology feature. Yeah. So the first step is that we first did the prediction by individual pathology feature, and I definitely believe that we can predict the pathology feature by CT radiomics. Yeah.
Excellent. Thank you so much. And also thank you for leading the world in this area, especially with regards to AI in thoracic surgery. Um,
Yeah.
Next week, we're going to talk a bit about cardio-oncology, and as always, there's too many questions and not enough time for answers. Once again, thank you to our sponsors, AstraZeneca, Medtronic, and Medillion Sites of Care, and especially to you, Mong-Wei, for leading this in the specific area of thoracic surgery. I thought your talk was very unique because many talks about AI in thoracic surgery talks about non-thoracic surgery-based AI. So yours was directly relevant to us. So thank you very much.
Yeah. Thank you, Eric. Yeah.
Have a good day. Bye-bye.
You too. Bye bye.